So for all of our residents, and we're lucky to have Dr. Patterson, the neurology side chair, both Morningside West, speaking with us on neuromuscular disorders. And that the slides look perfect.
Good, great.
Thank you.
Well, thank you so much for having me. It's a pleasure to be here, and Happy New Year, happy mid-January to all of you. And I wish we were doing this in person. This will be, not as much fun, but hopefully we'll make it as engaging as possible. And then we'll be in person sometime soon. And for those of you I haven't worked with, I'm Dr Patterson. I'll be on service at Morningside in February. So hopefully I'll get to see some of you around then, and we'll get started. So this is a huge topic, which is really like neuromuscular disease, also known as the peripheral nervous system, which essentially is the nervous system outside of the brain and spinal cord, of course. So we're going to be going through a whole host of topics on this. And I will just say in advance, we will be going through some of the things a little bit more like quickly, some of the slides, simply because there's so much content, and I want to make sure we have time to cover things and to emphasize also what I think may be sort of more directly relatable clinical points. All right, I get over here. All right, so first we're going to talk about anatomy, physiology, and neuromuscular testing. So this is just to start a little bit at the basic level, thinking about like what anatomy are we referring to when we talk about the peripheral nervous system and neuromuscular diseases. So really, on the motor side, the peripheral nervous system begins with the lower motor neuron, which is the anterior horn cell, actually physically located in the spinal cord anterior grain matter in the anterior horn. We have the ventral roots, of course, the dorsal roots, which are more sensory. And the cell body, or the ganglion for the sensory afferent fibers, is actually external, just external to the spinal cord, and what's called the dorsal root ganglion. And then this is, of course, kind of compressed for the sake of illustration, but we have the motor efferent pathways, which ultimately course down and connect to muscle. But we have the sensory afferent pathways, which in this case, I think they're illustrating through a stretch receptor, which flow in then to the dorsal columns of the spinal cord. And again, thinking about physiology of peripheral nerves, which we're going to be talking about a lot of peripheral nerve issues. This is literally something I took without giving acknowledgement here to the MCAT. I don't even know if the MCAT, I think it's probably changed a lot over the years, but thinking about basic action potential physiology, this is essentially what we're seeing as we see action potential or nerve action potential propagation down a nerve axon. So what we want to think about is that it's the same physiology, and this is in part why we see with so many nerve and muscle diseases, for example, channelopathies or different types of conditions that can impact nerve physiology, or even a lot of neuromuscular symptoms that arise from metabolic disarray. Is again, a lot of this is influencing just the basic physiology of the nerve transmission. One of the things we'll see a theme of in terms of peripheral nerve physiology is that a lot of the peripheral nerves may be myelinated. And in the peripheral nervous system, there is sort of a regular but intermittent pattern of the myelination. And then just to remind everyone that in between the myelinated segments are what's called the nodes of Ranvier. And this is where we see what's called saltatory conduction, which is really a way of speeding up conduction velocity in the myelinated nerves. So instead of the potential propagating down the entire length of the axon, it actually jumps, and it's saltatory. Saltare is Latin, I guess, for to leap, and it jumps between these nodes of Ranvier. And this is actually results in a faster velocity than we would see if the transmission had to occur continuously along the whole axon. The next thing I wanted to talk about is, again, the large diameter nerve fiber anatomy. These are like the nerve fibers that you might dissect in a cadaver, the median nerve, the sciatic nerve, and so forth. So these large diameter nerve fibers actually have a kind of a concentric anatomy that I wanted to mention. And it's relevant in cases of peripheral nerve injury in particular, which we definitely sometimes see in patients who may have had stretch nerve injuries or compression nerve injuries or lacerations. And this kind of allows us to understand sort of what the implications are for different types of nerve injury and why some are easier to heal than others. So the outermost layer is the epineurium, the layer in the middle is the perineurium, and then the innermost layer is the endoneurium. And the what we see in terms of different levels of injury, speaking for a most superficial level of injury, we call it neurapraxia. And neurapraxia, here you can see that the epineurium, which is the outermost connective layer that surrounds the whole nerve structure, is intact. The perineurium is intact. The endoneurium is intact. There may be some sort of superficial compression or some stretching, but we basically have an intact anatomy. Myelin is compressible. I think I had a mentor who once told me, kind of as a metaphor, that peripheral nerves, you can think of them as almost like a tube of toothpaste, and you can kind of squish it, and there is some compression that happens there. But as soon as you really compress the myelin, you mess up the ability of the conduction to occur, and that actually can relate to symptoms, kind of in the same way as a demyelinating lesion would. So you can have actually some of this very superficial injury, which we see sometimes in patients, that sort of classic Saturday night palsy, which you might see in some of your patients, which is really just somebody who has compressed the radial nerve against a hard surface, whether it's the side of a chair, and results in some symptoms. But if it was really kind of a superficial pressure injury, they may get significant improvement or resolution of symptoms within a day or two. So this is essentially the same kind of idea. Prognosis is good, but you can see here that the nerve structures are essentially intact. The next layer we think of is called an axonepnisis, which is sort of a next progressive layer of injury. This is typically seen with crush injuries. And we, again, in this schema here, we see there is some, as the name implies, injury to the axons. The surrounding stroma, the surrounding kind of supportive layers are intact, and they kind of form, if you will, a scaffolding for regeneration of the axons to occur. So in fact, you can have regeneration of peripheral nerve axons, which is a big difference than what we think of in the central nervous system with the stroke, or for example, in the brain or spinal cord injury in the spinal cord. We don't really think of central nervous system nerves regenerating that well, but we do see peripheral nerve regeneration. To be clear, regeneration it really requires a lot of different conditions to happen well. Regeneration occurs more effectively over shorter segments than over longer segments. So if you had a nerve injury at the shoulder, it would be very hard for the nerves to regenerate well all the way down to the fingers. It probably wouldn't happen. But also it requires really maintenance of this supportive structures here. So Wallerian degeneration, again, is what we think of when we have degeneration of axons, which have been damaged or severed from the main part of the nerve and the nerve cell body. When this occurs, we'll be able to see different kind of implications, even with Emg nerve conduction testing, and what this means clinically when you have a lesion that results in really significant axonal injury. Also here in this picture, it's showing kind of a depiction of like a complete axonal injury, if you will. But in reality, it's very common that we may have injury to a percentage of axons in a nerve. And then last but not least, we have neuromesis, which pretty simply is essentially severing of the whole nerve structure. This is obviously the most severe, the worst prognosis for recovery. And if, depending on the clinical situation, if, for example, if you had a possibility for a peripheral nerve repair, if this was a really vital nerve, somebody came in right after an accident, this might be an opportunity for a surgical reapproximation of the nerve endings. Moving along past the peripheral nerve, I wanted to speak about, again, thinking about the motor side, the neuromuscular junction for a couple slides. The neuromuscular junction is really important also, especially as it relates to a number of diseases like myasthenia gravis, might be the most familiar, where you have an autoimmune essentially a disease against some of these receptors that are involved in propagating signals through the neuromuscular junction. So the neuromuscular junction, again, translates the electrical signal, the electrical propagation that travels down the nerve, into a chemical signal through the neurotransmitter acetylcholine. And then it allows acetylcholine binding on the other side of the junction. And through the binding to these receptors, it then results in an M plate potential, which then ultimately summates and results in an action potential along the muscle. So it really is like an electrical, chemical, and then electrical again link that translates a nerve action potential into a muscle contraction essentially. And this is just another schematic kind of showing you, for the purpose of showing you again that the acetylcholine is packed in these vesicles, the pre-synaptic or pre-junctional terminal, and that the acetylcholine receptors are really concentrated on the crests of these post-junctional folds. A lot of this infolding at the postsynaptic membrane allows for a more robust kind of signaling through the neuromuscular junction, as opposed to just having a flat surface with some receptors on it. And again, each time acetylcholine from a single vesicle crosses and binds to a receptor, it results in a very localized small depolarization of the muscle fiber, and people have done experiments where they've really looked at this. But overall, we're looking at the summation of these small action potentials, which eventually triggers contraction of the muscle fiber through voltage-sensitive calcium influx. Again, we're starting to see like the relationship between a lot of these different ions and the physiology of nerves and muscles overall as well. Pivoting a little bit to muscle anatomy. So you see a lot of a kind of redundancy, if you will, between the patterns of like these concentric bundles of tissue, in the same way as we had the nerve axons surrounded by concentric layers of different connective tissue. You see a very similar anatomy in the muscles here, with individual muscle fibers bundled together in fascicles, bundled together in the muscle tissue with interspersed blood vessels, and then different layers of connective tissue over the muscle itself. So pivoting next to different types of testing modalities, what kind of tests do we use to investigate for peripheral nerve or muscle disorders? The first I would mention is neuromuscular testing is an MRI. And this is really the same MRI machine that we would use for any other MRI, but oftentimes the protocols may be different. What the radiologist may be looking for is obviously different. And I am sure that you've seen already on certain MRIs, people commenting on neuromuscular structure. So they may comment sometimes on muscle atrophy that they might see in some patients, or they might comment on inflammation that they see, or if there's a hematoma in the muscle. These are things that you probably have seen kind of in basic mention as sort of complications, if you will, from other types of medical conditions or procedures. Routine MRIs generally do not resolve peripheral nerves very well. There are certain types of very kind of more high-tech techniques called MR neurography, which is a special technique designed to image those nerves. It is not available here, but it is something that can be obtained in certain specialized imaging centers. And I think, we may see actually more interesting progress in this area in the years to come. But common patterns that we can identify are muscle atrophy, fibrosis, physical injury, or inflammation, which meaning enhancement, which does require contrast. This is an image showing some diffuse hyperintensity in thigh muscles in the patient with dermatomyositis. And this here, what we're seeing is the vastus lateralis muscle with the arrowhead over here. And also there's some increased signal in the subcutaneous tissue, essentially where the vasculature is, and that's the arrow here. So again, you can kind of definitely appreciate that this muscle is lighter. This is enhancement from inflammatory cell infiltration in the muscle of a patient with dermatomyositis. This is probably not a typical protocol, but sometimes we will ask for special MRIs looking at patients' thigh muscles or other things to look for this. And as you may imagine, obviously, this is a pretty non-specific picture. So seeing atrophy or seeing inflammation, it's not going to tell you which exact disease is at play. But again, at broad strokes, it can identify some patterns and some areas of concern that you might follow up with some other types of tests or blood testing and so forth. Neuromuscular ultrasound is a technique which has really taken hold over the last decade or so. It is something which allows you to use basic ultrasound to really visualize in a detailed way peripheral nerves and muscles. Again, something that many of you who have done ultrasound or seen ultrasound can probably imagine. There are parts of neuromuscular fellowships which are dedicated to this, and it is very operator dependent, where people who are good at it can literally kind of map down, moving the ultrasound over the length of a limb, map down the course of individual nerves as they kind of undulate and take different courses over the nerves. They can identify if there's a compression of the nerve. They can identify if there's pathological enlargement of the nerve, which we can see in certain dysmyelinating or demyelinating conditions. So it is much more sophisticated than kind of a routine ultrasound. And we actually, I just wanted to put a plug here on purpose in case you were wondering, do we have this? We do. So at Mount Sinai West, Dr. Rory Abrams actually offers this mostly in our faculty practice at Mount Sinai West. But we have had some rare occasions where there have been inpatients where we've had some concerns. There was a patient with a fistula, a dialysis fistula, that had a strange, sort of had morphed in a certain way and was actually compressing some forearm nerve structures in a way that was hard to delineate on EMG. And he was able actually to directly visualize it with the ultrasound as a follow-up, and the patient was taken back to surgery to correct the issue. We are also in the process of expanding this to Mount Sinai Morningside, where it will be offered by Vanessa Tiongson at our faculty practice there. So this can be really, it's non-invasive. It can actually, with the in the right hands, answer a lot of questions. Sometimes there are patients who might have carpal tunnel syndrome, and they have such young, healthy nerves, if you will, that their values on their nerve conduction studies might look normal, but on the ultrasound, they can actually directly visualize some subtle compression of the nerve to help confirm the diagnosis. So there's a lot of different applications for this, and it's pretty exciting to see. I think I used to have a version of this with more examples, but in the interest of time, I've taken these off. But if you have any interest, you can just Google neuromuscular ultrasound and look under images. You'll see a lot of interesting things. Nerve and muscle biopsy. What's interesting is, I think over the years, as we have had more sophisticated serum testing, especially for different autoimmune conditions and other types of imaging studies, we definitely do use nerve and muscle biopsy. I think it is somewhat less common than we used to rely on it in the past. But this is obviously a way of directly evaluating disease pathology in muscle and nerve, and also the associated connective tissue and vasculature, because the biopsy isn't just looking at the muscle fibers or the axons, but you're again looking for any diagnostic changes in the connective tissue or in the vasculature in the same sample. And in general, and at our institutions, they are performed by surgeons. Many of the surgeons we work with here in orthopedics and neurosurgery can help us with these. There are certain people who go through fellowships in neuromuscular disease where they learn to do the biopsies themselves. And really, we want to partner closely for these, as you may imagine, with a very experienced neuromuscular pathologist. So we have some great relationships there. This again is just a schematic of what you might see for a normal muscle tissue. These is essentially looking at a cross-section of the individual muscle fibers and a cross-section of a normal blood vessel. This again is just an example of what you might see in dermatomyositis, where we had a lot of inflammatory cells infiltrating. And this is an actual slide of a muscle biopsy in a patient who had dermatomyositis. So, but again, a lot of inflammatory cells, the dark purple dots infiltrating the tissue. Another type of biopsy you might have heard of is actually that relates to neuromuscular disorders is a skin biopsy, looking at small diameter nerve fibers in the skin. So this is actually offered by a number of our providers in our practices. It is a routine office punch biopsy with local anesthetic. And the goal is really to image, when it's sent to pathology, is to image these microscopic small diameter nerve fibers, which are in the skin. This is these nerve fibers they're not something you could directly visualize through dissection. We actually cannot detect these in isolation on EMG or nerve conduction testing. And some patients have isolated small fiber neuropathy. So their EMG nerve conduction may be normal, but they may have small diameter sensory symptoms, burning, tingling. And then what we're able to do is confirm a diagnosis through the skin biopsy, where we will look for reduced epidermal nerve fiber density. That's really all you're looking for. They can also do certain stains to look for amyloid or other things like that, but it's not quite as elaborate in terms of different analysis relative to like a nerve and muscle biopsy. However, this has been useful lately in really allowing, and you can see a lot of the early literature is just within the last 15 years, primarily, more or less. And I think more recently, it's become more commonly available for patients who in the past wouldn't have had a diagnosis, or maybe they would have been diagnosed with fibromyalgia or something else, and lo and behold, we're able to identify a small fiber neuropathy on skin biopsy. And EMG and nerve conduction study testing. So you can actually, what we can kind of use this test for is to try to localize, first of all, is it a peripheral nervous system or a central nervous system issue? And again, we're able to test the large diameter nerve fibers, the muscles, and the neuromuscular junction. Most of the time clinically, we can tell if it's central or peripheral, but sometimes it's really helpful to have EMG nerve conduction kind of help whittle that down for you. From a nerve standpoint, we can actually tell what type of nerve fibers are involved, whether it's sensory, motor, or mixed. We can distinguish if there is primarily demyelinating pathology or axonal pathology. And even in certain patterns of demyelinating nerve pathology, we can tell with nerve conduction studies if it looks more of like a hereditary pattern or an acquired demyelinating condition, for example, like Guillain-Barre syndrome or CIDP. We can also use certain features of these findings to tell the temporal course. Does this look like something that's been chronic? Does this look like an acute pathology? And so forth. And this kind of just goes back to the different localization opportunities that EMG nerve conduction study facilitates. Certainly, we're looking for much more than neuropathy or myopathy, but we can use patterns of abnormalities to try to discern if there may be like a mononeuropathy, a plexopathy, radiculopathy, if there's a presynaptic or postsynaptic junctional disorder. When to order an EMG. So this is something that certainly may come up for you, especially in the hospital. If there's a patient you're wondering, would an EMG be useful here? So if the patient has had like relatively subacute or chronic symptoms and maybe they're fluctuating, then certainly, you know, the timing is not as much of an issue. The study can be done at any point. We see a lot of patients, of course, in the hospital who say, oh, I have had weakness or numbness, and it's going on for months. I feel like it might be getting worse or spreading. Once it's been going on for that long, it's fine. We should be able to pick it up on this testing if it's something that we can is detectable there. Obviously, of course, sometimes we look and see like how severe is it in terms of figuring out when or where to do it. And there may be some other kind of different types of timing considerations, especially if there's a peripheral nerve injury. So if you suspect that somebody may have had an injury to a peripheral nerve through an accident or compression or surgery or whatever it is, then there may be a different type of timing consideration where sometimes we actually do need to wait a little while in order to allow for the technique to most accurately reflect the full extent of the injury. So if in the case, again, of a neuromuscular injury specifically, usually we don't do an immediate test. Occasionally, there could be a role for an immediate test if you need to really just rule out if a nerve has been completely severed, although usually then it's obvious clinically if you think that that may be the case, and in some trauma patients, they may be having exploratory surgery anyway. So this is something that usually doesn't come up. The most common time frame for an initial study in a peripheral nerve injury patient is around 2 weeks. And at that point, why are we waiting that long? Well, if you remember a few slides back where we showed the schema of the nerve with Wallerian degeneration taking place, we need to allow time for the Wallerian degeneration to take place. Because before then, let's say if you have a, sorry, I'm getting the famous Mount Sinai message, my computer is about to restart. I am going to hit snooze. If I suddenly magically disappear, then you know it's not my fault, but hopefully that won't happen. So continuing on, I think that the Wallerian degeneration really needs to take place. Imagine that you had a nerve that was severed. And let's say you happened to be doing your testing, and it was very recently severed. The physiology of that nerve initially will still be intact, and you'll be able to potentially stimulate and record over that severed nerve segment, and it might look like a pretty normal recording. So it certainly would give you an underestimate of what the full range of the nerve injury was. And so in essence, we wait for about 2 weeks. At that point, Wallerian degeneration will have occurred, and we're able to see the full degree of axonal loss and also denervation in the muscle tissue, which has lost that connection to a nerve structure that it previously had. Occasionally, there will be patients who've had injuries, or maybe they had a problem and they had surgery for, and then we want to do a follow-up study to see, are they getting better? Or maybe it's not easy to tell clinically. We may do a follow-up study a few months later. We can look for reinnervation again in muscles that had denervation patterns. And we may do another follow-up study again, even several months after that. So we typically don't do follow-up studies for the same question any sooner than about a few months apart. Otherwise, you might not really be able to say meaningful changes from reinnervation or regeneration of the nerve. And in many cases, we may be doing like one follow-up study. It's not that common that we're doing multiple follow-up studies. The basic equipment in terms of an EMG nerve conduction machine, it really is just like a computer with a monitor and an amplifier and an area of, it's very simple. It comes in a lot of different sizes and shapes, from larger machine setups on a cart. They make these very compact kind of laptop-based setups, which some people use. This is a basic setup for a median motor nerve conduction. So this is the stimulator. There are actually a couple metal electrodes that you can see here. This one is the G1 or recording electrode, which is over the abductor pollicis brevis, which is innervated by the median nerve. And this is the G2 or reference recording electrode, which is meant to be essentially over another location in the area that you don't want it too far away, but that is relatively electrically inert. So we pick, for example, like a joint, which is what this is over here. And then there's a ground electrode, which is on the back of the palm. You can see the wire coming out there. So what do we get when we stimulate? What kind of recording do we get? Here is a basic motor nerve conduction recording. We call this the compound motor action potential, because that's really what it is. It's a combination of different motor action potentials. And it's a summation of these depolarizing muscle fibers under the recording electrode. So for motor nerve conductions, we're stimulating over the nerve and recording over an innervated muscle. And we measure a few different parameters. We measure where the takeoff point is from where the signal begins. So the machine will record that as a latency. We call that the distal motor latency, and that's the time that it takes for the transmission to travel down the nerve and cross the neuromuscular junction, and the muscle starts to depolarize. We measure the amplitude, which is generally considered to be proportionate to the number of axons. So if we have axonal loss, we'll see a reduction in the amplitude. And we record the duration, and then we actually physically take a tape measure and we measure the distance between where we were stimulating and recording, input that in for different segments, and that actually calculates for us a conduction velocity. And then we can look for any type of slowing or see if the velocity is normal. We can march. This was kind of one location we saw in the setup, but then what you can do is you stimulate here at the wrist, then you move forward to the forearm. If you need to, you can keep moving all the way up to essentially the location of where the brachial plexus is. So you can actually measure, if you need to, different segments of the nerves as well. Sensory nerve, this is a picture of a sensory nerve action potential, which is the sensory correlate in nerve conduction studies. And essentially we're stimulating and recording over the nerve. We measure the amplitude and the conduction velocity. The idea that, you may have heard of conduction block. This is something that we see sometimes in nerves where there's a lot of demyelination, with the idea being that there's enough demyelination to result in a failure of transmission across the nerve. So this is an example where we might have a bundle of nerves in one kind of larger nerve structure. You're stimulating at different locations, but the propagation is perfect. So you're seeing good waveforms. Here's an example where you can see a loss of myelin sufficient to result in a failure of propagation. And so you have a good waveform with distal stimulation, and with proximal stimulation, the waveform, there's some still getting through, maybe from this one here, but you see a big loss and a dispersion of the response. On EMG studies, so what are we doing with EMG testing? We're actually looking using a very small needle electrode, inserting that, which is a recording electrode, inserting just the tip of it into muscles of interest, and looking at three things. What's happening when the patient is not moving the muscle? What happens when they contract the muscle a little bit? And what happens when they contract the muscle a lot? And what are we measuring there? What we're measuring essentially is a motor unit action potential, which is, and a motor unit again is an anterior horn cell in the anterior gray matter of the spinal cord and all of the muscle fibers it's connected to. And they should, under normal physiologic circumstances, contract in concert all together and result in a nice organized looking waveform called a motor unit action potential. In cases where maybe there's been some sort of nerve injury, there's been some denervation and some reinnervation, while it's great because you can have reinnervation, you also may have a less organized anatomical relationship than you did initially, and a less organized looking waveform afterwards. So we call this, in general, this would be kind of a neuropathic pattern. There's a lot more phases. It may have a higher amplitude. And so there's also different patterns that we tend to see with myopathic pathology, which tend to be smaller waveforms, or neuropathic pathology, with these larger, more complex waveforms. Obviously, in cases with severe denervation, we may lose all motor units, and that would correlate clinically with severe weakness. We are also looking for an EMG, what we call spontaneous activity or abnormal spontaneous activity. So usually a healthy nerve muscle connection, under those circumstances, there's really no firing of the muscle of any significance without muscle contraction. And sometimes in cases where there's been denervation, there's disconnection rather between some of these nerve branches and the individual muscle fibers. And when that happens, it's almost as if these little individual muscle fibers have their own intrinsic, I'm going to call it a pacemaker, but it's not like the same as we think of as like the cardiac electrical pacemakers, but they have their own little inherent firing pattern that only comes out when they've been really physiologically disconnected from their motor unit. And you will see them firing away in these cases with their own also very small motor units, because that's just one muscle fiber, and in a very regular pattern, like the ticking of a timer or something, which is not something that you can physiologically reproduce. If you try to contract your muscle, you get a much different kind of irregular firing pattern that kind of summates. It's very, it would be, I would say pretty much impossible to mimic this. And also the waveform morphology looks different and it sounds different. So you can actually hear this ticking sound of these waveforms happening. These are fibrillations. There's another version of this, which is slightly different, but pretty much the same significance, called positive sharp waves, which are similar implications. There's other types of spontaneous activity as well, but we aren't going to go through all of the different types here. And lastly, the part of the EMG test that we're looking for is what happens when the patient tries to have a significant muscle contraction. What do we expect to see normally? We expect to see motor units firing and more motor units firing until we get what we call full recruitment, which is a lot of these motor units firing all at once and kind of a blackout, if you will. It's just kind of a ton of motor units everywhere. You can't even separate one from the other. What happens, for example, in a case where there's maybe been significant nerve injury, where you have a loss of a significant number of the normal nerve muscle connections, you will have the remaining motor units firing. They may look kind of neuropathic, like these are larger amplitude, and they're going to be firing faster and faster as you try to contract, but you're never going to get to that full interference pattern. And so here we see what we call a neuropathic recruitment, where you have faster and faster firing frequencies, but you never can generate that full interference pattern. And that's what we would call neuropathic recruitment. And it takes time to generate this because it only occurs after there's been some reinnervation. So you can have these neuropathic units. You can kind of start to understand a little bit how we're able to observe things here and say, this pattern we would only see in a chronic neuropathic process. So if a patient came in and said, oh, I've had some symptoms for the last 2 weeks, and then we saw this on their EMG, we might say, okay, maybe they've noticed it for the last couple of weeks, but based on what we're seeing here physiologically, this has been going on for longer. And then lastly, we have neuromuscular junction testing, where we're basically using different types of repetitive nerve impulses to try to stimulate the neuromuscular junction, to stimulate that acetylcholine release. And under normal physiologic circumstances, we should always be able to reach over a threshold in order to generate an adequate muscle response. So in any normal neuromuscular junction physiologic circumstance, there is a threshold that we have to cross to create an action potential, a motor action potential. But under normal physiology, we should be able to always get there. In certain types of neuromuscular junction disorders, this process breaks down and there's a loss of robustness here. And then that's where you'll see a failure of transmission because we aren't able to reach that threshold. And that's where we start to see weakness, for example, like in Mycenae Gravis patients. This is something I'm going to skip through, but if any of you are interested in kind of a pop culture correlate to neuromuscular disease, for those of you New York Yankees fans who've heard of Lou Gehrig. So Lou Gehrig was a famous New York Yankee who unfortunately succumbed to motor neuron disease, also known in some circles as Lou Gehrig's disease. And there's this amazing recording of him, which you can look up online, of his farewell speech. He was just like this incredibly humble speech that he gave the last time that he was there at Yankee Stadium. So that's something, if you are interested in a little history and overlap with neuromuscular diseases. Now I'd like to go into some clinical correlations, really drawing upon a lot of the principles that we've just covered in the first part. So when you're talking to patients and you think that you're taking a history and you think they may have like a neuromuscular disorder, there's certain things you want to ask them about that will lend you to thinking about neuromuscular diseases in different ways. Is there a pattern where they fatigue more with activity? That may make you think of a neuromuscular junction disorder, for example. Do they have different types of symptoms that point to nerve or muscle pathology, such as certain types of neuropathic pain, muscle cramps, twitching, or numbness? And when you hear them speak about certain functional limitations, it can imply different muscle groups impacted. Like if they have trouble climbing stairs, then you're thinking, okay, they may have proximal leg weakness or proximal lower extremity weakness. If they're tripping over their toes while walking, you're wondering, do they have a foot drop? Do they have distal lower extremity weakness? Do they have trouble combing their hair? Maybe they have proximal upper extremity weakness or some sort of clumsiness using their hands. They can't manage coins or turn a key, there's some hand weakness there. And getting into different types of specific examples, we'll start with motor neuron disease. We'll start kind of at the proximal end of the anatomy and work our way distally. So motor neuronopathies, and there is such a thing as sensory neuronopathies, although we probably don't see them as much in an inpatient basis. But motor neuronopathies, also known as motor neuron disease, when you have a mix of upper and lower motor neuron pathology, is ALS. It is not very common, fortunately, but we definitely see it. And I have seen not many, but a number of patients over the years who are hospitalized for progressive weakness of unknown etiology. And then it turns out that they have undiagnosed or previously undiagnosed ALS. The peak incidence tends to be onset in mid to late life. Does seem to have a slight male predominance. Most cases are sporadic, but there are rarer familial forms. But by and large, most cases are really sporadic. We don't know exactly what causes it. There's a ton of research that's ongoing. Many of you may recall the ice bucket challenge that came about a few years ago, where people were trying to raise awareness and money for ALS. But there's thought to be some sort of a mixture maybe of excitotoxicity oxidative stress or some immunologic component at play. Initial symptoms it can vary. It usually starts focally and then spreads to become more generalized in most cases. It may begin in the bulbar region with difficulty speaking or swallowing. It may begin in one extremity with weakness. Usually at the beginning, it's focal and asymmetric. Very rarely does it begin with a respiratory presentation. So we don't really think of it as something that would present with respiratory insufficiency. And the hallmark on exam is you're going to see a mixture of this lower and upper motor neuron signs in classic ALS with muscle atrophy, some flaccid weakness, and also spasticity and hyperreflexia in the same segment. You'll often see fasciculations or twitching of the muscle as well. In many cases, as a clinician, we can really have a very strong clinical suspicion for this in impacted patients just by examining them. And oftentimes we're really doing a lot of other testing though to rule out other mimics. There is no involvement of extraocular muscles, sphincters, the autonomic system, or sensation. So if a patient comes to me and says, I'm really worried I might have ALS, I'm having numbness and tingling, automatically, I may not know what they have, but automatically I can certainly say to them that, this is something that you don't have ALS. We just need to figure out what's happening. Mental status is usually normal. There's a rare kind of association with frontotemporal dementia in some patients, but again, that's a very, very niche group. Usually this disease is slowly progressive. There's a huge amount of variability in terms of life expectancy, which is dependent on a number of factors, including kind of the resources that the patient has, what the patient's own wishes are. But in general, we see a 5-year survival of about 25%, but there are some patients who survive over a decade. Patients who have a bulbar onset tend to have a worse prognosis because it is harder for them to swallow and they may have high risk of aspiration. I think we've gone through a lot of this. On EMG, we will see signs of the lower motor neuron component with a lot of denervation and abnormal motor unit potentials. Patients do not have muscle biopsies for diagnosis, but this is, some patients have had, and you would see denervation changes there. We do not have any cure. There is a lot of research ongoing. There are some treatments, and at best, the treatments are thought to possibly slow the progression or subtly slow the progression. A lot of the treatments focus on kind of blocking excitotoxic pathways. One example is riluzole. And a lot of the treatment is really about supportive care. So ensuring adequate nutrition, adequate ventilation, a lot of psychological and end-of-life discussions about goals, and so forth. But for some patients, I've definitely seen some patients who maybe had a lot of kind of quality of life, even when they were very disabled, if they derived a lot of pleasure from different intellectual pursuits that they were still able to engage in or spending time with their family. So it is a very humbling, I think, experience working with these patients in terms of, who defines what quality of life is and how we can support people in different situations. Moving along to radiculopathy. This is something you've definitely seen. Some of you may have experienced. Very common. This is basically pathology localized to the nerve roots, and the sensory and motor findings will follow along those nerve roots, sometimes increased or triggered by something that can be triggered by anything that really increases your intrathoracic pressure and maybe kind of enhances that. Any maneuvers that we're doing sometimes, like straight leg raise, is we're just trying to sort of stretch the nerve roots a little bit to see if it triggers the symptoms. This again is a dermatome map. So this is the map of where sensory symptoms may occur related to different nerve roots. This is a myotome map, and these are easy to look up, which is essentially a brief overview of some of the major muscle groups that are innervated by different nerve roots. And the pathology, of course, for each nerve root just follows along the dermatome and myotome. On EMG, it's like the same thing. So we tend to see for muscles, there's a little bit of overlap and variability and innervation of different nerve roots for different muscles. So there may be some overlap in different people. It's not usually like C6 is only, one muscle. It's typically like the deltoid may have innervation from a couple nerve roots, which is also why if you have a patient, even if they have a really bad nerve root compression, they usually don't have flaccid weakness in the muscle involved. There's usually some weakness and a lot of pain. But the reason why we don't usually tend to see flaccid weakness is because that muscle is usually innervated by more than one nerve root. But we do look at patterns on an EMG for radiculopathy. To pick up a good radiculopathy on an EMG, to be honest, it is not hugely sensitive, especially for mild or moderate nerve root issues, because in order to really pick it up well, you have to have denervation of the involved muscles. So a lot of patients may have radicular pain. We may see some pathology on their MRIs, but we don't pick up a lot on EMG, and that's not unexpected. But there are some characteristic findings. And of course, if you have inflammation like radiculitis from a hematologic malignancy or different infections, Lyme disease, then we tend to see a lot of findings pretty quickly because there's just like a diffuse inflammation that's causing pathology along a number of nerve roots all at once. I'm going to go through quickly over this. I think you guys have probably heard about nerve root kind of issues before, from like herniated discs and conservative management and physical therapy, NSAIDs, and so forth. Other types of diseases can cause nerve root pathology. So it's important to bear in mind, especially in patients who have these kind of radicular complaints, but just seem to have other constitutional symptoms of illness. Hematologic malignancy can infiltrate nerve roots. Diabetes can cause ischemic radiculopathy. Infections can cause radiculitis. In these cases, non-contrast imaging won't necessarily show you anything. So you might end up needing to have a contrast MRI if you want to look for nerve root inflammation or enhancement. Lumbar puncture is often indicated, of course, in some of these cases to rule out some of these illnesses, and EMG can be performed, although it's not necessary if you have all the other diagnostic pieces matching up. Moving on to neuropathy. So neuropathy is really common. You've definitely seen it. It's something, there's acute versions we only see usually in the hospital, like Guillain-Barre. The most classic kind of stocking glove presentation usually begins as distal and focal or symmetric. This should be purely lower motor neuron signs, so no hyperreflexia, no upgoing toes. And when there's a chronic neuropathy that involves large diameter nerve fibers, we start seeing muscle atrophy. So you might see people with atrophic foot muscles if they have like a diabetic length-dependent neuropathy. It can involve a variety of different motor fibers, types of nerve fibers. So you might have a patient with longstanding diabetic neuropathy who has numbness and pain in their feet, maybe trouble with balance, but then they might start having orthostatic intolerance or dizziness, and they might actually have a different type of autonomic nervous system involvement from the neuropathy as well. Again, not to forget that there are the large diameter nerve fibers causing neuropathy, and also you can have that isolated small fiber neuropathy we talked about with the skin biopsies. And then large diameter, we break it down even more. Axonal neuropathies are the most common, and most common cause is diabetes. Demyelinating neuropathies are relatively less common, but when we see them, it really points us usually toward like an autoimmune condition, which is important because it can have implications for treatment that we don't have as much in the axonal neuropathy realm. So it's important to make that distinguish, and that's where EMG nerve conduction comes into play a lot of the time. Just as a quick trivia point, on a global level, now diabetes is the most common cause of peripheral neuropathy, but before we had a sort of a epidemic or pandemic of diabetes, if you will, can anyone guess what the most common cause of peripheral neuropathy was? It was leprosy, which I think is kind of interesting. It kind of speaks to, and occasionally you will see patients with leprosy. Usually they've maybe just moved to New York, or they've been, traveling or something like this. But it's interesting to think about the global burden of certain diseases, which here we don't see, and we're not used to thinking about. So Guillain-Barre is an acute immune demyelinating polyneuropathy, also known as AIDP. I'm sure many of you, if not all of you, have seen it or certainly heard about it. It often follows minor infectious processes. It's really something that like triggers the immune system, and then the immune system acts out and like misfires against your nerves. That's really what we're talking about. So there's some idea that maybe certain there's like molecular mimicry between certain types of viral structures and nervous system structures. But honestly, we can see this, as you very well know, following like sort of a revving up of the immune system that goes wrong after vaccinations in some cases. Even I've heard of it after certain surgeries, that may be kind of an immune hyper-inflammatory response, or after childbirth. So it is not common, but the most common examples we think of follow a viral infectious process. And distal lower extremity paresthesias are the initial symptom in about half of patients. Again, this is something that comes out of nowhere and is evolving quickly over days. It's really an acute process, and then followed by weakness, which again usually begins symmetrically and distally. There can be rapid progression and ascending weakness. Some people can have relatively mild courses. Some people can have really substantial weakness in all four extremities. In about half of patients, they may have kind of reached the low point of their weakness in about a week. But for some patients, it might still be progressing, and this is kind of par for the course for even several weeks. So for some patients, it can be confusing, because I've seen patients where, they come in, they get diagnosed, maybe they get IVIG, then they finish their IVIG, they go to acute rehab, and then somebody thinks they're getting worse, they get transferred back, and then everyone's wondering, did we miss something? Is something going on? And lo and behold, actually, it might be that this is kind of still within their natural disease course progression. They just need more support. Sometimes they get another course of treatment, but we don't have to like call into question everything that we've come up with so far. Rarely, ventilatory support may be needed, again, in more severe cases. They can have autonomic nervous system dysfunction. One of the hallmarks we look for on their physical exam early on is loss of the deep tendon reflexes, or hyporeflexia, areflexia. And the CSF provides a characteristic feature, which is what we call albumin-cytologic dissociation, which means that you will have an increase in protein, essentially from more or less a debris from the demyelination, but you do not have an increase in white cells. And so this is not like a radiculitis or meningitis. It's an autoimmune demyelinating condition. Nerve conduction studies, actually, if you do it really early on, you might see almost nothing. You might see some F wave loss or abnormalities. But it is, if the patient especially is getting EMG nerve conduction study within the first couple days, we may not be able to pick much up. And in many cases, we make a diagnosis and a recommendation for treatment based on the clinical picture, the CSF, because we don't want to delay starting treatment. Treatment is oftentimes, these are kind of listed here in different orders, but obviously supportive care. We usually do start with IVIG because it is there's sometimes less of a complication profile relative to plasma exchange. 70% of patients recover completely. So for most patients, this is really something that it may take them some time. They may need some outpatient visits for some residual pain management or physical therapy, getting their balance back, but the prognosis is good for the vast majority of patients. Very, very few, I would be surprised if this is even smaller percentage than noted here. I think very, very few patients die of this. And there is a chronic version, an autoimmune demyelinating neuropathy, which is a chronic demyelinating polyneuropathy called CIDP. And it is not something, it is not usually the case that like a Guillain-Barre patient goes on to have CIDP. It's usually something that arises really separately with kind of a chronic, slow, progressive or relapsing course. And the diagnosis in terms of the chronicity is usually made with 6 months at least of a progressive or waxing and waning symptoms. Many patients have a combination of sensory and motor deficits. They may have CSF studies. For these patients, especially when the time course is chronic, we should be able to see all of the diagnostic findings on their EMG after it's, once they're kind of meeting the chronic thresholds of timing. And the treatment can be complex for these patients. A lot of them, especially if it's a chronic treatment, they might be on IVIG, but a lot of these patients end up on chronic kind of different non-steroid immunosuppressants. Diabetic neuropathy, you could have obviously a whole talk on diabetic neuropathy, but this is just a fast overview. It affects a lot of diabetics, and a lot of times it's subclinical. So they may not have the neuropathic pain, They may have more kind of loss of balance, for example, or they might have, again, some of the autonomic features with dizziness. It is, again, very common for patients who do have sensory symptoms. It tends to be the stocking glove presentation, begins in the feet and the lower extremities, may then later progress to the upper extremities and progress up the leg. Treating, essentially, like taking care of their diabetes is really the best type of treatment for slowing the progression. And then for patients who have pain, pain treatment is important. It doesn't obviously change the underlying condition, but it's important in terms of their quality of life. And also, not on this slide, but I would add for patients, a lot of them will have balance problems because they have lack of sensitivity on their feet. And so it is very important also to counsel them about balance. And some of them might benefit even from physical therapy at different points. There are many, many other causes of acquired peripheral neuropathy. So a lot of times if we have a patient with neuropathy, we'll do these, some other blood tests or history kind of screen to make sure we're not missing anything, especially something that might be easily kind of correctable. And even in patients personally, if they come to see me and they have a diabetic neuropathy, I usually at least do some basic blood work looking at different vitamin levels, their thyroid, making sure at least those have been checked so we're not missing something else that's especially easily addressable that might also be contributing. There are hereditary neuropathy. Charcot-Marie-Tooth is probably the most well-known. And there's different types of Charcot-Marie-Tooth. This is a different type of like dysmyelination. So there can be thickened myelin appearance as opposed to demyelination, which is a lack of myelin. This is somebody who was known as the Great Charcot, I guess, who identified this, but they have a really untreated, they have this really like deformed foot appearance because their muscle strength, which normally really interacts with the skeletal structure of the feet, has not been there from early in life. So a lot of these patients actually will have a lot of foot surgeries if they have access to care to kind of try to correct this so they can actually walk and have more of a normal life. They'll have these very, very thin appearing legs because they haven't had a normal muscle development. Moving on to neuromuscular pathology, getting toward the end here in the last couple minutes, we tend to see a classic fluctuation of weakness, weaker when they're using the muscle, and then if they rest, they feel stronger. The weakness may be somewhat patchy. It doesn't have to be global. Obviously, there's no sensory changes. Reflexes should be normal. Tone is usually normal. Mycenae Gravis is the most common neuromuscular junction disorder. And the most common antibody is against the acetylcholine receptor, and there's different subtypes of that. They may have association with other types of autoimmune disorders. Some patients have a thymoma, and it's thought that thymoma is linked to their autoimmune myasthenia gravis. And for patients who have even thymic hyperplasia or thymoma, there's been studies that have shown great success in sometimes resolution of the myasthenia or fast improvement with the thymectomy. So that's actually something we tend to look for and do imaging, especially in patients when we're making the diagnosis. This tends to have a more female predominance and tends to start earlier in life, like young adulthood. For many patients, the presentation is ocular. So they have weakness of their eyelids, essentially. They may have extraocular movement weakness. So they may have double vision, especially if they're trying to look in one direction for a while. They may have ptosis, other bulbar weakness perhaps, and then sometimes other generalized weakness. Respiratory failure as a presenting symptom is, again, very, very uncommon. The majority of patients have ocular involvement. Many patients will end up staying just with ocular myasthenia and not develop generalized myasthenia. And some patients, as time goes by, they may develop more generalized myasthenic symptoms. The hallmark, again, is this rapid fatigability, which we try to elicit on exams. We may have them look up for like a whole minute and see if after that time they develop ptosis or they develop diplopia. Symptoms classically are worse later in the day for patients, and often symptoms can be worsened in certain situations, which kind of add more fatigue, whether it's stress or illness, pregnancy, and there's certain drugs which famously can make myasthenia gravis worse. So for patients who have it, we often make sure they carry around or know this list so that they can talk to their doctors about it. Clinical findings is a big part of the diagnosis. We send the lab work to look for the antibodies. We may check the CT for thymoma, and then we may do nerve conductions to look for that pathological decrement on the repetitive nerve stimulation, where with repetitive nerve stimulation, they can't reach the threshold like we would normally. This is actually an appearance of that, just to show you where there's repetitive nerve stimulation. And here you can see the kind of electrophysiologic correlate to that weakness, where they can't maintain that same action potential and you have a pathological decrement. And that's essentially what's happening. That's why patients get weaker with activity. It's just there's not enough robustness because of the lack of functional acetylcholine receptors because of the antibodies. And so neuromuscular transmission breaks down after a couple iterations. This was just kind of a description of the physiology that we described there, to go through that here. One of the basic mainstays of treatment is essentially to try to boost the amount of acetylcholine in the neuromuscular junction with acetylcholinesterase drugs. Sometimes you can have too much acetylcholine and result in a cholinergic crisis, so we always watch out for that. And then because it is an autoimmune condition, we do rely on other immune system medications, whether it's steroids, other non-steroid sparing immunosuppressants in some cases. For some patients, they may need ongoing or sporadic IVIG, and thymectomy for patients really who have a thymoma, or even for thymic enlargement. Myopathies, to finish off, weakness is usually more proximal. They may or may not have atrophy or weakness. Reflexes are normal. Obviously, there's no abnormal sensory symptoms or autonomic changes. There can be inherited or hereditary myopathies, which are usually referred to as muscular dystrophy. Duchenne's is one of the most common forms of muscular dystrophy, which is X-linked. Onset is in childhood by 5 years, and you tend to see like toe walking or waddling, inability to run. There is a somewhat of a limited lifespan, unfortunately. And on exam, these patients tend to have this calf pseudohypertrophy. So they're weak, but their calf muscles look really large. This is actually the dystrophin, which is the molecule that has the mutation that results in this myopathy and muscular dystrophy. This is a picture of a boy with this Duchenne's muscular dystrophy. You can see the calf pseudohypertrophy, and he's exhibiting what's called the Gower sign, which is he's too weak to kind of just stand up normally. So he's actually sort of using his arms to like brace himself and try to walk himself up to a standing position. You may see also an elevated CPK. You need to screen for other types of muscle involvement, such as the heart. They may have mild intellectual impairment. There's really, again, no treatment in terms that's really notable, but there is maybe some benefit with prednisone, physical therapy, and adaptive equipment. Acquired muscular diseases usually involve inflammatory changes with like polymyositis or dermatomyositis. Much more common in adults, somewhat more common in females, maybe subacute, slowly progressive. There you may have, with the inflammation, as you may imagine, tenderness or pain in the muscles. We usually say elevated CPK. Muscle biopsies can be very helpful in these patients because we'll also be able to visualize the pattern of inflammation in the muscles. Different types of immunosuppressive drugs or prednisone may be useful. And oftentimes these patients may have kind of a partnership between a rheumatologist and a neurologist for their care. Dermatomyositis also has a cutaneous manifestation with that erythematous rash around the eyes associated with the condition. And there's many other causes of myopathy as well. Some of them can be really relatively reversible and not too complex, especially in cases where there may be untreated thyroid disease. HIV can, of course, cause different types of myopathy. Different types of medications can have different muscle complications. Alcohol chronically. So we always try to think about these factors as well for patients. And that's really the end. So thank you. This is like a real whirlwind tour. And I hope that you will have a good day. I know we kind of run over by a few minutes, but if there's any questions, you can try to slip them in, or I didn't see any coming up in the chat, although there was some great discussion about Lou Gehrig in the chat. And you can also reach out to me separately or grab me in the hallway.
Thank you so much, Dr. Patterson, for covering so much in that time. If it's okay, we might leave it there. I see Dr. Citrin is waiting for the next talk as well, but thank you so much for your time, Dr. Patterson.